position. And I want to thank them for coming, and Dr. Sharma for giving us a medical perspective on all of this.
I will try my best.
Sure.
I'll just do it. Because I'm going to talk for a long time. I'll give you guys plenty of time for questions. Don't worry about that.
Hi everyone, my name is Caroline Crandall. That is my husband Jonathan. We are the owners of Green Theory, and so we're really happy to be able to bring Dr. Sharma in today to talk to you all about cannabis, medical cannabis, and how we supply that at our store if you are interested after this in potentially trying it out. We are located down the street, just 4 minutes away on MacArthur Boulevard, right across from the CVS. We do in-store pickups and also deliveries, so we're available to you whenever and wherever you need. But yeah, I hope this is really informative for everyone today, and we'll be here for questions afterwards as well. So thank you so much.
So before I jump into this whole talk, I really felt what you said, because the reason why I jumped into this space was access. I've been working as a hospital medicine physician for the past 17 years, various hospitals all across Maryland, Virginia, as far away as Michigan. Oh, I can shout as loud as you guys are comfortable. Do not worry.
Just err on the side of shelling.
That's not a problem. But over the years of practice, you run into scenarios in different parts of the world. Let's say you're in the distant parts of Maryland, you're in parts of Virginia that have kind of forgotten, parts of Pennsylvania that are that way. You run into lots of trouble. You run into meth, you run into drug addiction, you run into people with pain, you run into people without access or resource. And I always tell myself, in this day and age, not having access it's not a good thing, We live in a society that should have access to anything and everything in a safe manner, not in a wild kind of have a party, guys. No, that's not what I'm here to say. But I'm here to discuss why access is important and kind of the reasons and the medical reasons why. I'll preface this by saying, let's see, my training started at University of California, Berkeley as an undergrad. I did my med school at the University of Iowa, so I know what the middle of the country is like. I can tell you all about it. I went back to LA County, USC to train back in California. And that was a moment in time when they started legalization in the state. And what she described was a scenario we would run into with HIV patients and folks who were dying of cancer. They were like, hey, as a last resort, we're making this legal for this population. And being a resident in clinic, you're always excited. You're like, hey, I just tried everything. I prescribed everything. This guy's still looking like he's not going to make it. As a last-ditch effort, in my last 2 years there, I started sending people to Venice Beach. It's like, if you go to Venice Beach, sir, take the bus, go all the way to Venice Beach. When you get to the end of that line, just walk down the beach a little bit. There'll be a guy with a table. The guy with the table will register you to go up to their clinic and get registered for cannabis. And it was a weird experience. But that's what it was like in the beginning. So I would tell these folks who looked like, they were wasting away, hey, this is an option. They would come back and I'd see them in follow-up. And I'd see them over and over again until I graduated. And if there's anything that kind of makes you go, maybe we thought about this wrong. Maybe we didn't quite put it all together into a good story and give people the right access. Those are the kind of moments you see as a doctor. Like, could we have done this differently? The answer will, in this case, be yes. So I'm going to try to give you kind of the nerd part of this, the part I love, all the kind of the physiology, where does this work, how does this work, and kind of give you a little bit of that. I'll get into kind of dosing and safe dosing, because I think there's a safe way to do this, and then there's the Wild West. And I prefer as a doctor to prescribe, well, recommend, you can't use the word prescribe, because that's the way, there was litigation that allows a doctor to discuss this with patients and recommend it. But no one's allowed to prescribe, because that goes against the FDA and all the other stuff that's out there. So I'll try the best I can to stay within my lines and give you guys that information. And where do I practice right now? I small telehealth practice. I service some patients all across Maryland, Virginia, Pennsylvania. But my full-time profession is still not this. I still work within the hospital. I'm a medical director at Adventist White Oak, and I still take care of patients full-time. I do this more or less for access. So that hasn't changed. So I'm going to go through my disclosures. I'm going to go through the overview of cannabis. This is kind of the flow that I hope to maintain. Because we're a small group, you're allowed to stop me at any point in time and ask questions. Because I've gone through this talk many times, so I can go back and forth in which way. I don't have my accessory slides on this computer, so I can't give you like the NIH deep down dive, but I can give you parts of that. THC versus CBD, why is that good to know? What does that mean in terms of dosing? Dosing forms, recommendation. The normal adverse effects, if this is your first time trying, I don't think we talk about that. That's very important to know. And then if you're going to take this and you're taking medications, what should you be afraid of? What should you be looking for? And then, like I said, question and answer. So the purpose of my talk is to just give you those fundamental basics on how it works. To make sure we kind of go over the safety part of this more than anything else.
So if you don't prescribe, doctors don't prescribe it, what we're saying?
Doctors are not allowed to write a written prescription that says cannabis, but they are allowed to give you a certification and recommendation.
And that's all you need.
For most, for the states that have medical programs, that's what you need. And for the states where it's legal to use, you won't need that. But, you know, I'm here more or less to provide that additional instruction and safety right now. Now, I've done this multiple times. That's what this slide is about. I'm going to kind of jump ahead. This is the more exciting stuff after I go through disclosures. So all the information I'm sharing is not supposed to be a substitute for your relationship with your individual doc. I'm just doing this for more or less educational purposes. I can't do any diagnosis or treatment from the stage. That would be amazing. I would love to be that doc, but I have not been able to do that. I can do visual diagnosis from here, but not much else. Participants are encouraged to consult with their own healthcare providers and to, you know, seek detailed information about what they need to do that. The use of cannabis is still subject to federal, state, and local laws, and that is still true. In fact, if you're next to any federal territory, I usually say, even if you have medical cannabis or anything legal, do not use it on federal territory. You're playing with a law that is a little bit more harsh. Won't have any recourse. It is the responsibility of every individual to safeguard how they use and to find their safe means of access and use. This lecture and I myself do not endorse illicit use of any drugs. That's not my flavor. That's not what I like. But I do encourage safe use and safe access. The other thing that's really interesting is over the last couple of years of recommending this, I can tell you that there are categories of people that react the same, but it's interesting to see that there are no two people that will find the same result from the same material. There are some really fascinating studies, if you like, studies from Canada. When Canada legalized, they did a bunch of really interesting studies. The one that I really loved was about migraines. And so they wanted to see, because, you know, they were in the big business side of it. They're like, if we could find a miracle drug for migraines, we're going to package this and sell this to the whole world. So they did a huge study on it. And what they found is that everyone broke up into quarters, but there wasn't one winner. Meaning everyone responded to the plan a little bit different. And that's what makes this a little bit harder to say, this is the one for you, this is the one for you, this is the magic pill. There's no magic pill. You have to find what works best for you. So individual results vary, therapeutic benefits vary, and it changes, you know, the conditions that we can use it for. For some people, works optimal. For other patients, so-so. So I cannot guarantee any specific outcome. I do not have hard data. I have some hard data, but there's a lot of soft data that I had to parse into this talk. So when I say soft data, that means either the volume of patients was on the lower side, or the study wasn't randomized and controlled, or there were other little factors that added to it. The Canadian ones, though, they tend to be controlled, they tend to have all the bells and whistles. But they also were looking for different things that didn't quite match my head. So if there are any adverse effects, realize that, I want everyone to be responsible for their use. I'm not here to say condone the wrong stuff. So this is all for educational purpose. Please be aware of your local cannabis law. Here in DC, it changes a little bit, so you just have to kind of be aware. I was paid a fee to speak, and I want to disclose that openly. I was paid, but I'm not an employee of Green Theory. I'm not an employee of anyone else. I work separately. I'm just here to provide information. So the fascinating part about cannabis, they didn't give us this slide in med school. In med school, when I look back at the actual text, there were about 4 sentences about the endocannabinoid system. And it was, the endocannabinoid system exists, there may be something to cannabis, and that's all it basically said. What we know now is based on the research of Raphael McCullum and Wolf in Temple University back in Philadelphia. And they did the original kind of isolates on THC and kind of the receptor system that it belongs to. And the most fascinating thing is, inside of our bodies, a whole system that kind of regulates a lot of the stuff we're looking at. So as a doc, we sometimes think that disorders we're dealing with out there might be disorders of the endocannabinoid system. When I look at the Society of Cannabis Conditions, we have hypotheses. We're like, oh, this may not just be chronic pain. This may be a deficiency we're seeing over and over again. Do we have the research and ability to prove that right now? I can just say hypothesis for now. That's just a function of federal regulation. It's very hard to do cannabis research. Last time I saw cannabis research was in med school, though. There was a study done on anorexic patients at the University of Iowa. The lead author was my attendee, and I was like, sir, what do you have to do to monitor this? And then he said, well, I'm a registered member of the ATF. I am licensed to get this federal cannabis from Mississippi. Mississippi was the main place to make it, University of Mississippi. And every ounce and everything that's doled out has to be accounted for. If anything is missing, I have violated federal law. I'm like, oh, that's really easy, huh? What about your participants? Oh, we have to enroll them, put them through a screen, and then, so the good news is that's where we get the anorexia and the cachexia type information. It's from actual studies, but they were difficult to do, low volume, and it's hard to generalize to large populations because of that. So this is kind of one of the results of kind of going, hey, why is this working? So the endocannabinoid system is a system of receptors that sit within our bodies. We have 2 receptors that we talk about the most because they're the most well studied. I'm going to show those kind of to you guys. It's called CB1 and CB2. This gets boring. Anyone wants to yawn? I can move on to other things, or if you have questions, please ask. But CB1 and CB2 were the first 2 that we studied. And if you look at the NIH website, there's a fanatic who really kind of reports all the recent data. There was a guy I met a couple of years ago. He would kind of put together that there are actually up to 6 receptors that we accept as interfaces for cannabis oil in our bodies. Now, we don't fully know what all of them do. So I can't claim the anti-cancer benefits of one of the receptors. I can't fully claim kind of the sleep and anxiety benefits of one of the other receptors that's out there until we fully study it. But just imagine that this plant can actually hit 6 of our receptors in our body. And it's one of those moments where I always think nature is beautiful. That, we have this plant that we have made illegal, but it interfaces with 6 receptors in our body and actually can provide therapeutic benefit for a large population for low cost. So it always makes me scratch my head a little bit, but this is kind of the general framework. So there are 2 main receptors. There are 2 endogenous hormones that our body makes that are similar to cannabis. The first one we call anandamide, and that was named by McCollum kind of in a meditative fashion. And the other one is 2-arachidonyl glycerol. I'm going to shortcut call it 2-AG. So your body is already making 2 little hormones in stress responses to different physiologic needs on a regular basis. There's a natural degradation pathway for these enzymes, so the biochemistry is solid. And the picture we have here is what we think of as the normal signaling pathway, which is you have a nerve going to a cell somewhere in the body. And at the end of the nerve, the hormone secreted hits its target, and then you get the target response. This has been studied even further. There was, if you look at this little funny looking chart right here at the bottom, this is looking at, this is postnatal age. In different age groups, there's a different expression of these hormones and these receptors. I point this one out because there's a reason why we try to tell kids not to drink early, smoke early, or to use any sort of drugs early. There's a natural tendency for addiction when things are exposed early. This kind of shows that nature part of that. So even though it may look like a bunch of squiggly lines, that to me means there's a warning sign for young kids and young adults. As we age though, there are natural moments where things get lower hormonally and natural moments where they stabilize. Where in the body are these receptors? That's the entire body. It's head to toe. You have CB1 receptors located in the brain, the immune system, the lungs, the vascular system, your muscles, your GI tract, your liver, your pancreas, your reproductive organs, your bone marrow. And on the CB2 side, it's the immune system, skin, liver, bone marrow, pancreas, spleen, and bones. So we were built with this. This wasn't me introducing a receptor into your body or the big pharma people or whatever new conspiracy we're going to come up with, but this was built in. Now, this is kind of a summary of receptors. These are the top ones. The TRP1, TRP2, the GPRs. I'm not going to talk about those as much. They're still in the research phases of learning. There's some suggestion that some of these receptors are part of cancer pathways and such, but we don't have any data. And right now, they're just more up there for speculation's sake. But CB1, CB2 are recognized, and they kind of highlight all the parts of the body that it fits by color. So then it comes down to where can I use this? Is this good for me? Is this gonna take me on a rocket to a different planet? How's this gonna work? The answer is the sky's the limit on what we can do. This lecture takes me back to when I saw way back when I was an undergrad at Berkeley. There was a crazy guy from the Oakland Cannabis Club, and he gave a lecture to us medical pre-med students, and he put up this ridiculous slide. And it was, these are all the things cannabis could treat. He put 400 diagnoses across the wall. And all of us were looking at each other like, how could that be? After this many years of kind of studying and looking at it, I can agree with some of those now. You know, I'm a skeptic. It takes me a while to kind of come on board. I need to see data, I need to see evidence. So he was right, but I'm not sure 400 yet. I'm kind of at 100. But these are kind of the top things that we have some evidence for. So the things that have the strongest evidence are going to be chronic pain, but mostly pain that involves neuropathy. So that burning pain that happens to hands and feet, musculoskeletal pain, injury pain, inflammatory pain as well. So when I think about pain, pain isn't just pain in my head, and I should probably pause for a minute and go why. If I tell you I can treat your pain with X medication, I want to tell you that doctor is a moron. Pain is complicated. Pain is not simply receptor to injury. If we use that paradigm, we will injure the population. And that's what we saw during the opioid epidemic, right? We treated everyone's pain with pain medication, said, I'll make your pain go away, I'm gonna be the greatest doctor ever. And I feel like we killed and doomed too many people because we didn't think about pain correctly. So I'm just gonna give you 2 minutes of why I say that. You injured, let's say, one finger. That sends pain fibers in that finger to send a signal up your spine. that signal doesn't only go up your spine, but it goes through a cascade of areas in your brain. It goes to the front of the brain through the social centers. It goes through the limbic centers, which are the emotional centers of your brain. And then finally, it's going to hit a target on your brain and says, ding, 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 you injured your finger, you burned your toe, you did X, Y, and Z. Which means that pain is more than just an injury. It's a social, it's an emotional state. And if we don't recognize those components of pain, we will harm more people. So when I say pain here, this is pain, but this is one of the treatments for pain. You have to address all the other forms of it to keep yourself healthy. So I hope that makes sense. There's a neuropsychologist that did a talk about this, and I'm the biggest fan because I'm like, wow, I think we were wrong, you know? I think that turned it off.
Computer's still on.
It's just this one to see. Technical difficulties, but
Hit the space bar.
that's okay. We will find a way to get that back.
Shut everything off and shut it back on.
Yes.
Everyone's using what I call the cell phone method, right? Just turn the phone off, turn it back on. Turn the phone back. Not worried.
There we go.
So, chronic pain. So chronic pain, nerve pain, muscle pain. That is one area that's been studied, and there's consistent evidence to say there's some benefit. I can't tell you 100%. What type of benefit or what will help you, but there's some benefit. Chemotherapy-induced nausea and vomiting. I can't tell you how awful it is for folks going through therapy, and I watch them over and over again at the hospital. The nausea and vomiting that happens doesn't only affect kind of how you feel, but it's even more intense when you start to realize that this person's metabolic needs have doubled and they can't eat. So when we're addressing nausea and vomiting chemotherapy, whether it be with standard medications or cannabis, we're giving options to allow that human being to regain that nutrition that's missing. So just keep that in mind. So there are FDA-approved drugs that are cannabis-related for this very problem, and it's dronabinol and nabilone. Most oncologists already know this, but they also know it might be cheaper just to go get cannabis from the dispensary. Now, spasticity, multiple sclerosis, there is some debate whether this is 100%, 50%, or 60% true. What I've seen in practice and time is when my folks with major sclerosis, when they come and see me, I remember in my head vividly, I had a population that came from a nursing home to the clinic. And they would come in walkers and canes. And the next year when I saw them, they were doing more. The guy went from a walker to a cane, the other guy went from a cane to just walking into my office. I was like, what happened? And this is how they put it. So it may not be that it's fully treating muscle spasm, but imagine that you could kind of distract your brain away from pain and do therapy. Now you can stretch and exercise. And so I was seeing the progress that was happening. So I think that's where the studies have it sort of right and wrong. So just FYI. Moderate evidence for sleep disorders, and there are pro studies and there are studies that go the other way on this. So some folks say that sleep is disturbed by cannabis, others say it kind of helps. I have at least 500 patients that'll say it helps. So I tend to lean on it, it's probably right. Anxiety and PTSD, and I wrote in parentheses, more research needed. The reason why is, it's kind of interesting to watch folks go through different traumatic events. Not that it's fun for me, but I see it a lot. Trauma in the brain are very unique, and one's initial ability to react to dealing with a traumatic event is not really good. There's a lot of flaws in the way our brain works. It actually stops working for some people. And we have to recognize that as a society. If a traumatic event happens somewhere, there's a shockwave that just went through that population. So now you have folks who are in an emotional state, can't respond and react or process very well. That initial wave of shock will involve what I call early PTSD, where this helps to forget the event. Later PTSD, it's sleep disturbance, it's hyperarousal, it's other things. So once again, there are two different ways to use cannabis for this population, is what I'm trying to say. But I've seen reasonable results in the veteran population that we treat. So epilepsy was one that got a lot of fanfare. This was about like 6 years ago. Oh, we have these children who have these intractable seizures. Two syndromes that used to be a death sentence for young kids. It was Dravet syndrome and Lennox-Gastaut. Their uncontrollable seizures never stop, and they eventually can't eat, can't function, and die. These were the group of people that said, if I give them CBD oil, and they named them after different kids, this will get rid of it. One was called Charlotte's Web. I found that the epilepsy side it's useful, and for some of the adults I use as well, they see the same benefit. So there's moderate evidence for epilepsy. Emerging, and I say this with caution because I've gone through every memory study you could think of regarding Alzheimer's, because I have family members too. And we always want to treat everyone as early as we can and look for solutions. I'll say the memory stuff in my head is still on the emerging, but there is a mechanism of action that is reasonable, and they highlight it there. So there's evidence of reduction of inflammation. It turns out that a lot of what we eat inflames different parts of our bodies, and cannabis works as a very strong anti-inflammatory, especially CBD. So because of that, there may be a response in folks with Alzheimer's. The Parkinson's side is more on the epilepsy side of it, anti-tremor, anti-seizure, anti-spasm. That's where it tends to do its work. And then inflammatory conditions like Crohn's and ulcerative colitis. When these patients first came to me, I was like, you mean cannabis? Can you even eat it? You know, it's sort of like that. This is going to be horrible. But what I found over time is I made a lot of friends with these patients. I've listened to how this has affected their lives. They shared with me colonoscopy results, almost like baby pictures. This one, look, it's all clean. And I'm not kidding, that we did see progress in this population that I've been following. So I do believe that's probably going to be a big deal in the future. And then cancer, but note I put in quotes, symptom control, nausea. I don't feel well. I don't have energy. I don't feel like eating. For symptoms, I feel it's very therapeutic. In the beginning, there was these kind of wild tales about a wildly Canadian guy who basically made what was called Rick Simpson oil. He said it was the cure to everything. I don't believe it, but because of him, there were a group of cancer patients that first came to me going, "This is the cure," and I was like, "This is not the cure. I'm not convinced." I want to still play the skeptical line a little bit, but I will say that I do have a subset of cancer patients that are still doing very well. There's some of them were stage 4 breast, others were prostate, and they're still coming to me and talking to me. So I want to say, I don't want to take any credit. I don't want to say it's all cannabis. I want to also give their credit to science and where we are. But there may be something to Rick. I'm not sure. That's all I'm going to say. If you ever want to see his video, it's wild. Rick Simpson, YouTube. Okay. Limited evidence, and this is where I will actually look at some of if we look at ER literature from the minute a state legalizes to the minute they go recreational. Most emergency rooms will complain of a syndrome called cannabis hyperemesis. Cannabis hyperemesis, in my mind, is related to limited evidence of depression being treated with cannabis, and I would agree with that. The usual character is a female between the age of usually preteen to about 30. Undiagnosed, untreated underlying depression or major anxiety. Basically, sought cannabis to treat all that. The problem with cannabis is, and this is from the National Science Academy research, cannabis is a weak SSRI. SSRIs are the medications we use for depression. So if you're taking a weak medication and you have to take a higher dose over and over again, you can develop toxicity. That toxicity is cannabis hyperemesis. So that's why, I feel like depression and bipolar are in the limited evidence category. We think we see more trouble with it than benefit. Are there people using it for that? The answer is yes. Are some of them very successful with it? Surprisingly, I can nod my head and say yes, but is there a way to guarantee everyone that? No, absolutely not. Glaucoma was studied at the University of Southern California Eye Institute, Norris Eye. The guy who studied it did this wild study where he'd make people smoke and then he would measure their eye pressures. And I'll tell you, we've all gone through eye pressure measurements, everyone in this room. They put that little thing on your eyeball and you see the light. That was his research. And he was able to prove without a shadow of a doubt that you can decrease eye pressures with smokable cannabis, but he could never make a cannabis drop. So there is no eye drop that involves cannabis to decrease eye pressure. It's a transient drop in eye pressure when you smoke it or use it, but it's not long lasting and we don't have a way to dose for that. So glaucoma, even though it's popular as a glaucoma, I'm getting cannabis. It's an okay use type of thing. I've seen reasonable results with it. Folks have stable disease while on it. I think it's because it's comfortable. Okay, more chemistry. So this is the
temporary.
What's that?
You say temporary.
So
Like a day or.
when I get to the when I get to the dosing side, I will focus on that and I'll tell you about like how many we have estimates. I'll give you some estimates. This is a biochemical. This is what we want to make. I wish I had that on my t-shirt. This is THC and CBD. This is the one that got all the bad press in the world. Right? This is illegal. This is going to get you high. This is going to make. They made videos about this back in the 30s and 40s. That was amazing. Low quality, more fun to watch. Save it for a good evening. But chemically very similar, and they hit these similar receptors. We think CBD works more with CB2 receptor, and this was CB1. It's still kind of a debate because they both can. They're very similar, so they can actually interlock into both of these. So keep that in mind. They both do different things, though. So I'm going to kind of go through some symptoms and things they do. Medical uses of CBD. So CBD is the one that got all the press for, we treated all these kids with it, their seizures went away. So anti-seizure is number one on that list. It works as a pretty potent anti-inflammatory. It does analgesic pain in terms of inflammatory pain and swelling. I don't think about it as morphine level pain control. But if you think about Tylenol, ibuprofen, that's about CBD. Anti-tumor effects, I did not bold. Antipsychotic effects, I did not bold. Inflammatory bowel disease and depression, because these are lower on my list of, I'm not sure. But the top three that I would say CBD does are right there. THC, on the patients I've studied over time, I definitely say it has an analgesic and a pain effect. Similar to morphine, but not as potent. Definitely not as strong. So folks who have definite bone breaks and need that level of pain, cannabis may help, but it's not going to take it all away. Anti-nausea effect, that's a THC effect. Appetite stimulation, that's a THC effect. Glaucoma, we know is a THC effect. Sleep aid, I'm 50-50 on. Some people are like, that's great. Some people are like, that's okay. But it does have an effect. Anti-anxiety, for some folks, it does work. It's a distractor. Imagine you're focused on something. The world's coming to an end. The world's coming to an end. Oh my God, what's going to happen in January? And then you take a little bit of this and you go, I don't remember what's happening. It's anti-anxiety effect. Muscle spasticity. So when I talk to folks about what to prioritize in their cannabis, this is how it splits up in my head. So if you need pain relief, you need both. If you need anxiety relief, you might dip a little more to the THC side. If you need relief for nausea, dip a little more into something with higher levels of THC and CBD. I usually encourage people to get both, because if you have both, you can do what we call micro dosing, meaning less medication for more effect. both molecules, the nerdy side of this, both molecules kind of stabilize each other at nerve end plates and at receptor sites. And so if you have one, it blocks the degradation of the other. So it takes less of it to get more effect. That's more cost effective for most of my patients and most of our community, and that tends to do people more justice. So even though I've kind of separated it out into two, I usually want you to think about both of these as part of the medication. Question? Did I lose everyone? Go too far. If I go too far into the science, just wait. Stop. You know,
I guess the big question is, how do you start by figuring out what you really need? I mean, and we did go to the dispensary and we got one thing, but it seems to me you need a regimen of variety of different things to finally figure out what works. Because everybody, as you're saying right now, is everybody's different. Everybody reacts differently to the different medication, different types of marijuana.
So, good question. I'm going to get to both of these in the next couple slides. Let me give you both the bridge. When I get to this the section on smoking, that'll answer the glaucoma one. The glaucoma treatment lasts about 2.5 hours if someone smokes. And they can measure it, find a measurable drop in pressure. As the THC level spikes in the bloodstream and in the body, those muscles will relax. So that's 2.5 hours if someone smokes it. If you eat it, it doesn't reach such a high level, but it reaches enough to decrease the pressure some. So the edible lasts 8 to 10 hours, and that's where that helps the glaucoma. And what you're saying specifically with, so depending on symptoms, and also depending on time of year, depending on what a person's going through, our bodies change. So say you're in a good mental state, you're eating healthy, you're feeling good, the sun's out. The same cannabis that worked in the wintertime I found for my patients doesn't work in the summer. Because in the wintertime, we're not eating as well. We're not getting sunlight. We're not out doing all these things. Our body isn't in its optimal. And because of that, we see seasonal depression and all these other things play a role in our life. Our sleep cycle's off. Everything's a little off. When we get to summer, everything is like, it's like birds in the air. Things are great. So things can change seasonally. That's number one. Things can change month to month. You could have a month where your main symptom is pain in my knees and my back. Well, we work on treating some of the inflammation and getting that under control. We work on the social parts of that, the emotional parts I have in that type of pain over a long period of time, and we provide something to help with sleep, a little bit of pain relief. And you're able to do activity. That's how we kind of balance all these problems and get you therapy. That may look for you something different in winter than summer. And depending on how your body reacts to these two components, it may look different from person to person. There are folks that are very THC sensitive. THC sensitive means they even smell a little bit of it. And they're like, oh my God, my heart's racing. I don't know what's going on. I'm starting to sweat. And that's kind of a THC effect. So there are folks who are highly sensitive to that. Folks who are sensitive to that, when they're picking their form of this medication, will have to choose something that's more CBD heavy and focus on these symptoms. Won't have as much success with those. Someone who's going through cancer and pain may be choosing something that's more THC heavy. And they'll have to find their dose based on what's at the dispensary. In the past, I used to dive into all the stuff at the dispensary and bring them out and say, hey, this is the products will change month to month. You have to rely on a good dispensary owner that has good education, good knowledge to teach everyone out there what's available. And that's why I came to talk with these guys. I trust them. So, just keep that in mind. That's part of the answer. And we'll go through a couple more slides. Stop me again if I miss it. I will. Just stop me. So 3 basic ways to take it. And these ways are phenomenal because when I think to college, no one would ever tell me that an edible was something you could use as medication. I thought that was how we killed people. There was a math department cookout one day at Berkeley. And somebody was selling brownies and they had a little star next to it. And that cook made the newspaper that day because 2 people ended up in the hospital from those brownies. So back in the day, we're like, well, you can make it, but the stuff we know now and the way it's cultivated and made, edibles have an actual kind of bioavailability and kind of a treatment that it delivers, kind of similar to a pill medication. Smoke has a bioavailability that we can predict and that we know. These are studies that were kind of cruel, but done in the past, where you take blood, blood tests as people are using it. So. And then I wrote least favorite in patients over 65. I want to point that out. Cardiovascular disease and smoke, doesn't matter what type of smoke, it's smoke. Smoke is smoke is smoke. It may feel like better smoke from cannabis, but it's still smoke. And smoke causes heart disease. So in folks who have any cardiovascular risk factors, we have to give you that warning. That was actually from the ACC, they published that about a year ago. I was like, really? Smoke is smoke. That's what I've been telling people the whole time. So cannabis edibles, let's start with where therapy might be the best and it might help people more. Cannabis edibles kind of have a couple rules that we say that a lot of us practitioners in this area will say, as well as a lot of the nurses will say, as a lot of the dispensary owners will say, because these rules have been tried and tested over and over again, and it relates to bioavailability. And edibles is a slow-acting beast. It works slowly. You have to be patient with it. Tylenol and ibuprofen do not work in 10 minutes. It takes about 90 minutes to 2 hours to feel those medications kick in. And that's because of the normal pharmacologic curve that happens when you're taking a medication. And the same is true for edibles. The nice thing about what we have these days is a good lab-tested piece of cannabis. You can predictably know how much CBD THC is in there, and you can dose it by milligrams, which we didn't have that before. Those brownies that they sold probably were 30, 40 milligrams, enough to make you fly a rocket for 8 hours. This is not that. So what we're shooting for is the lowest dose edible, and our advice is go low, go slow. And we say that as a mantra, go low, go slow, because it lasts 8 to 10 hours. If you goof an edible dose, you're watching 3 seasons on Netflix. Okay, you've gone through all of Cobra Kai season 1, season 2, you're thinking about 3, then you're starting to kind of come back. 8 to 10 hours of time, depending on the dose-dependent amount that was taken. I knew a dispensary owner that once accidentally took a whole cube of something he wasn't supposed to, and he was out for 3 days. So go low, go slow is a safety mantra that I want everyone to think about and to use if you're going to use this. 8 to 10 hours is how long it lasts. It's not going to effectively kick in until about 90 minutes for most people. And if you have any sort of gut-related issues that affect your other medications, it will affect this as well. So the benefit of this, low dose, it maintains a low active dose, not a high active dose, a low active dose. And if that's all you need to deal with a little pain, a little anxiety, a little bit of nausea, that's great. That's what we emphasize. Low active doses and microdoses are important for the next reason, which is interactions with medications. I have a whole table of that I'm going to share in a bit too. There are a whole bunch of kind of things that can happen. We want you to know that. If you've never tried an edible of cannabis before, your CBD and THC amount should be about equal because you don't know which one and how you're going to react to it. The effective dose and recommended dose for folks over the age of 65 is 2.5 milligrams total CBD and THC together. It's a very low dose. And then the normal way I kind of coached people into safety is you try that little baby dose the first day. You may feel it, you may not feel it, but just try the little one. See how your body reacts to that first. Then you can do a dosing trial. And a dosing trial is where you take a little dose at 2.5, you wait an hour, you already know it's not effective for you, you wait for that hour to pass and take the next dose. You wait another hour. The first dose you took is fully bioavailable and active. The second dose is probably 60% there. At hour 2, you can judge, is it worth trying a little more or not? If it is, you try again, and you see if 7.5 milligrams gets you to goal. And you go slow. That slow is important. Why? If you took a little 2.5 over, good news, not 3 seasons, maybe 1 season of a show of your choice. All right? So you might have overshot a little bit, but not a lot. Safety is important. I'm going to go into the symptoms of what that feels like in the 3 more slides, so that'll answer some of the questions of what does it feel like to get the wrong amount and what to look out for. So 2.5, safe starting dose, both of them together 50-50, so you have 1.25 of this, 1.25 of that, and you just slowly trial it out, find out what the best option is for you based on that. Once you know how it works for your body, then you can start editing one way or the other. I need more THC, I have more nausea, and more of these muscle spasm symptoms. They really keep me up at night. I need something to help me sleep and deal with that. Okay. The next round of trying it out, try something that's a little bit more gifted on the THC side and less on the CBD side. Do the same dosing trial, take it slow. There is no benefit, this is not a race. It's a race to watch TV if you do it that way. Next thing. Topical cannabis is amazing. I don't think we talk about this enough. I think everyone's always focused in the movie set of, oh, look at all those gummies and all that stuff they're smoking. No, topical cannabis is fascinating. I've treated family members with this and friends with this, and I've seen some pretty amazing results. It works as an anti-inflammatory. There's no systemic absorption. You could smear it on your forehead all the way down to your toes. It'll be very hard to get a blood level out of that. It'd be almost, there are a couple movies, there's a movie called Train Spotting, don't watch it, but if you do, there are some ways to actually get a blood level, but don't do that. Topical is very hard to absorb into your bloodstream. Now, because of that, there are other medications I'm going to mention too. It's this doctor problem I have, right? So there's more than just cannabis for this. There is Voltaren gel that was formulated specifically for folks who are on multiple medications. Works as an anti-inflammatory available over the counter. This capsaicin cream also depletes substance C, which does another pain pathway. It can feel like burning fire because it's capsicum. Capsicum comes from chili powder. Do not touch your eyes, your nose, or anything that's precious if you use capsaicin cream, or you're going to feel that for hours.
You say it doesn't absorb, then how does it work?
This is that's an interesting part. So the absorption is local. So it's local absorption. So if you want to get the best result from these 3 powders and creams, you're going to put it very close to what's inflamed. So let's say I have an old knee injury. I did a lot of dumb stuff when I was younger, and now I'm feeling it. It's good. The winter months are coming. My knee's swelling a little bit. I'm limping. The knee itself, based on its anatomy, has certain access points. An access point is a point where the joint space is very close to the skin. This stuff can penetrate probably 1 to 2 millimeters down. And if we put a lot of it, maybe a little bit further, let's say half a centimeter max.
So the more you put on, the further
It may go. So we put it right on the inner part of the kneecap. There's a point that you can feel both bones. If everyone just touches your knee and you feel right, your kneecap's right here, you move a little bit next to it, you're gonna feel both bones. And as you move, that's a joint space. If I were to advise the cheapest and most effective way to use all these medications, you don't smear it on like lotion, especially not capsaicin. You find a specific area that's inflamed, get close to that joint space, and that's where you massage a little bit. So, best example I have was my mother-in-law went through knee replacement surgery. It's quite a painful, swelling type of ordeal. And I didn't tell her orthopedic doc, but I was smearing on her other end of her knee away from the wound. I was putting a little bit on there just to give her the anti-inflammatory relief. Took away some of the swelling, made her go through therapy better. Was it all the cannabis or was it the ibuprofen or Tylenol? I'm not going to speculate on that, but it felt like I did something, so I had to celebrate. Yay. You know? That's how I think about the topicals. The topicals are a little bit of anti-inflammatory relief, any of these ones you use, but it has to get close to the target. Places that are hard to get to, let's be honest about those. Your spine sits behind a lot of tissue. So to reach the spine is almost impossible. You will get muscle relief, and you'll get relief of everything sitting above that area, but it will not be able to go down that deep. Knees, pretty easy to get to. Hands, elbows, another spot you can feel will be right there. Shoulders, not so good. Neck, there's some skinny people out there who probably do it, but I'm not one. Knees, ankles, feet, probably reasonable. So I think of this as a nice way that you're gonna go dancing on Friday, you wanna get everything ready to go. You just, you get your goods clothes on, you massage a little around the knees, and you just get out there and have a blast. You won't even be high. But you may feel like you can do more if things were less swollen or inflamed. So that's how I think about this. Doesn't last very long. Most topical lotions, ointments out there, at most you get 4 hours out of, at most. 2 is what I see most people say. So somewhere between 2 to 4. And it has to be used on a limited basis, but you can't smear it all over your body and get it relief. It'll be a waste of money. Just focus on the areas you can get. Questions before we move to the next? Okay. All right. I go over smoke with everyone more as a safety thing. I don't always recommend it. Smoke actually does have a therapeutic place. So there are folks out there that go through emergency situations, panic attacks, PTSD folks who are about to pick up an M4, run out the door, do some crazy stuff. There are all sorts of moments where someone is going through a traumatic event. Smoke tends to be a way to calm that down. So I don't fully discredit it as a treatment, but it has its place. It's not for everybody. But because folks explore, I usually want to make sure you know what smoke is like. Smoke is the fastest acting way to get active, bioavailable cannabis in the body. It will take minutes to about 30 minutes to hit its peak, and then the liver and the body will start degrading it rapidly, about 2.5 to 3 hours. Depends on liver function. It's out of favor for me as a recommended area, mostly because of the cardiovascular risks that exist. I want to keep my patients healthy. I don't want to get heart attack or strokes. I don't always talk about this, but you should know how it works. And I call it the break glass in case of fire. Incredible pain, cancer pain like you wouldn't believe, or nausea you can't control with regular therapy. You deserve to have something in your pocket to help you. And that's where I think it's helpful. Does that make sense? And this is another little nerd tidbit. In the Society of Cannabis Clinician, we were taking bets and kind of going, well, how much is 1 puff of smoke really have? We guess it's between 5 to 7 milligrams of active oils absorbed from 1 deep inhalation. So it gives us kind of a running estimate. We could be wrong, but average size lungs, probably around 5. Male lungs, maybe 7. But somewhere in there is the truth. So what to look out for?
That's for 1 puff.
Yeah, from about a puff.
1 puff is like several pills.
Yes. So if you were to take a puff, we would say take a very light one, not a full inhalation, not a full deep one, because it would be 2.5 hours of Netflix in that case. Now, normal reactions to THC. Normal reaction to THC is to feel your heart beating rapidly. We call it tachycardia. And a little bit of jitteriness. Same thing is true of withdrawal from cannabis. It's like a little bit of tachycardia and jitteriness. So if it's your first time using any THC products, you may experience a sensation that your heart's beating up, so you feel it in your neck. And that's a normal kind of finding. It's something that as the body gets acclimated to will go away. There are other effects I panic more about, and I'm going to go over those. The effects of the kind of sensation, they will decrease over time in use. So say you found your ideal therapy, but you kind of feel that. About a week of using it, you won't feel it as much. Short-term memory effects of cannabis. The National Science Academy published a whole dissertation on behavioral health and cannabis. They had all these wonderful articles. So I read the one on memory in detail. And the way they describe it is memory effects with cannabis are short-term and they're temporary. If the mind isn't acclimated to THC, it kind of interferes with short-term memory. So that's why they make movies like, Dude, Where's My Car? Okay, because it affects short-term memory. You know, they made a whole movie about it, right? So in about 4 to 6 weeks of use, the brain gets acclimated for most folks, and those little short-term memories usually fade. High dose use is what I discourage the most, but let me go over high dose use. High dose use usually means you're on a rocket ship, you are high. High means psychoactive effects. Now, psychoactive effects with age also mean dizziness and falling. So that's where I urge caution. You know, if you do accidentally get to the 3 stages of Netflix, please don't operate vehicles, please don't drive, please don't do anything heavy, please don't mow the lawn, please don't, you know, do any sort of dancing or moving around. Just nice, cool place with a chair, 1 glass of water, and you'll have to kind of wait it out. So if you do accidentally get high, you know, the recommendation, just kind of wait it out, don't do anything miraculous. It does happen to some patients. The first year Maryland went medical, the ER visits were kids who accidentally gave grandma and grandpa little too many gummies. And they were out of it for a good 24 hours. So that's why I say go low, go slow, find your ideal dose. And please, 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 if it does hit your lung, consider kind of waiting it out. Medication effects. There are a lot of medication effects to be aware of. Let me preface this slide with one major fact. If you are low dose using, these medication effects aren't really going to matter because it takes a significant dose to get the liver enzymes revved up to do all the stuff that's here. So if you have a significant dose, somewhere around probably 10 to 20 milligrams of daily usage, that's where we see the cytochrome system in the liver get affected. When we affect that liver enzyme, it's going to either turn some of the medications into working better or working less. And that's what the last box are. What are the potential effects? What is it interacting with in the body? What are examples of the drug? And what are the medication classes? So one to be aware of, and I get this a lot, when I'm on blood pressure medications, what could happen? Your blood pressure could improve. It's amazing what happens when the body relaxes and the blood vessels on your body relax with cannabis. Your blood pressure medications could work too good. Another one to be aware of that's on here, if you're on opiates, we try to say, try not to mix and match. This is where the anesthesia recommendations come for procedures, where they say, if you're going to go for a major procedure, stay away from cannabis for about 5 to 7 days. We think that the mixing and matching isn't very safe. A little unpredictable. We don't like unpredictable and controlled environments. We want to deliver the best care we can. Other ones that are interesting. Things with drug level and dosages like warfarin kind of go up and down, but we haven't seen a real change with Eliquis, Xarelto, or any of the newer medications for anticoagulation. So I can't say those have any real dose effect or change, but warfarin does. So if you're on warfarin, we would say it's good to check drug levels. Immunosuppressant medications work too good with cannabis, so high dose cannabis and immunosuppressants for, let's say, a kidney transplant. You want to be aware that the dosages could go up in your body due to toxicities. So those doses may have to be dropped. So that's one kind of and antifungals, antibiotics. The usual rules for antibiotics are the same for everything. Please don't drink, smoke, or use anything while you're on antibiotics. It all messes with the antibiotic levels. They can go up or down depending on what you're using. The same is true for cannabis. Maybe those are kind of the highlights from this, but please take pictures, ask questions. And this is just a continuation of that slide. Question and answer. I'm here to answer anything you want. I also brought t-shirts. These are from our clinic. You can take them, use them as a brag, whatever you need. You know, I brought hand sanitizer because it can't be clean enough. It's COVID season, I guess. I'm not joking.
So,
Yes.
so again, I'm not quite clear. Suppose I wanted to try. Minimum.
Okay.
Like, just go into the store or we don't get a prescription.
In DC, they can come straight to the store.
Yep. So in
Okay.
DC, it is the medical dispensary, so you could come to our store and we can help you sign up for a med card. You don't need a doctor's recommendation in DC. It's all self-attestation. So it's basically you understanding that you want to try it, you're a grown adult, and you can say that and get your med card. So we can sign you up. The med card allows you to shop at a medical dispensary. So because DC is not a state, we're unable to start a recreational market right now. And so all of the legal stores are medical.
All of the legal stores, no.
Yep.
Legal stores, the places that have tested and trusted material.
What documentation do you need for the store?
So you need to bring a driver's license or some sort of government ID. But if you are a DC resident, you will get a card with your driver's license for 6 years and it's free.
Just your driver's license?
Correct, just your driver's license.
An issue we're with Kaiser Permanente, and I've asked our regular doc
The
about.
Kaiser Doc sent everyone to meet in Maryland, so I know that Kaiser won't give you the
They won't even
recommendation.
talk about it.
Yeah.
Which is, so what do? Talk to you?
So, I mean, because you're a DC resident, you know, after, if you feel comfortable with the information you have, you can go straight to the dispensary and register.
We did.
And then if you need to,
But I'd like the professional.
if you need a consultation, I'm always willing to see anyone I can, but I can't prescribe these things. I always have to work with that. I'm licensed in Maryland, Virginia, Pennsylvania.
The other thing is when they're dispensing, we did get a gummy, but does that have both the THC and the CBD in it? And then how do you?
So it depends on, we'll answer that question.
At our dispensary specifically, we have some edibles that are a 1-to-1 ratio. We have some edibles that are a 2-to-1 ratio. We have some that are pure THC. We don't have any right this moment, but in the next week or two, we should have some 20-to-1, which is 20 parts CBD to 1 part THC. So if you come into the store, you can ask everyone what different options we have, and we have a menu online that'll show you all the different ratios for edibles.
Well, we did that, and it wasn't really clear as to how you would, because I think what I'm hearing is you really have to start balancing and seeing what works for the specific patient.
Right.
It's all different. So I wasn't getting that kind of, unfortunately, that kind of information. And it was like you had to purchase a large amount, which didn't allow you to sort of gauge what you really needed.
Yeah, well, I would say one thing that we can recommend the next time that you're in are lower dose edibles, like Dr. Sharma mentioned, that have more of that balanced dosing for the CBD and THC. And then we also have edibles that you are able to cut to create the specific dose that you're looking for. And so I apologize that that's not what you received the last time in terms of the consultation. But that's another reason why we are also using Dr. Sharma, because we want to make sure that our store and the employees that work there are educated and able to assist in whatever you need.
I think that's the most important.
Absolutely.
Issue of how you get the right effect.
Exactly, because we're not medical professionals and it's actually illegal for us to give like specific recommendations. So that's why we recommend that you talk to someone who is a medical professional to get the assistance from them in terms of what you should be taking, and then we can lead you to a product that has those, that
So
dosage.
you can't make recommendations.
So we're not able to give like, oh, you should take this for this specific thing. It's kind of a gray area of what we can and cannot do. But we are able to tell you about the products that we have, and we'll say, this has the potential benefits for sleep, or this has the CBD that you're looking for in it. But because we're not medical professionals and we, don't want to have that liability, we can't actually say specifically.
I got a
That's a
question
little hard,
related to that.
because it's not, you're sort of not.
But that's why we recommend you talk to a doctor.
And our.
I know.
She won't talk to us.
Right.
I think scheduling a consultation with Dr. I will say too that all the products are like lab tested in DC, so all of the items in the menu are like tested in the lab. So if it says one piece is 5 milligrams, half CBD, half THC, it's exactly accurate.
I'll come back.
Okay. Appreciate it.
Medically registered with what?
With the state.
With the state. Oh, okay.
Keep your hands clean, keep your.
So yeah, so in DC, not being the state, we do not have any registered medical professionals.
In DC is kind of an interesting story. You see the laws, I've seen change so many times that I can't really tell you what the laws are. I know that they're following a set of laws that are very specific to what they can and cannot do. But there are some folks operating illegally all over the DC area that don't follow the laws and the rules.
But are there doctors in DC, medical doctors who can?
There are that we'll talk about it, but not as you guys can do.
Dr. Sharma,
Yeah.
you say you can't prescribe it, you just recommend it?
Yes.
So can a person from DC go to you for recommendations,
Yes, they can. They can.
like a consultation?
I can get consultation. Advice, I'm always willing to help people with advice. So, main thing is to preserve access. I do.
You should definitely.
You know where that get in trouble transporting it.
Yeah, that's.
Do you mind if we share your slide deck?
Sure.
Okay, if anybody wants the slide deck, I can send it to you.
Yes.
First of all, it's a topical question. I know. But secondly.
Well, they forget.
I haven't heard that specifically, but we